myself, Dr. Arohi Abhinav Jayaswal. I am assistant professor at Jawaharlal Nehru Medical College, Bhagalpur, Bihar. So today I am going to say a few words about latest update in hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to CVD, which affects 45% people in the 40 to 69 age group. Raised blood pressure is among the most important risk factor for CVDs. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has gone up over 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guideline. The inclusion of optimal and essential treatment paradigm attempt to address the issue that in resource poor settings, the optimal care refers to evidence based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The American Heart Association has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD risk. Among low risk adults with stage 1 hypertension having blood pressure systolic 130 to 139 and diastolic 80 to 89 millimeter of Hg, management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, then we should consider starting pharmacological therapy. Acute respiratory distress syndrome (ARDS) is a potentially fatal condition involving lung damage, and experts among associated with severe COPD, COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to 110 to less than 130 millimeter of Hg range substantially reduced cardiovascular adverse events in the STEP randomized trial, affirming that the sprint findings for an older Chinese population. Among some 8,500 patients aged between 60 to 80 years in China, the intensive target trimmed 26% of the composite cardiovascular risk. From now, a second major trial supporting a lower target could unite the guideline, which even among US professional societies range from threshold of 130 to 150 millimeter of Hg. With regards to prognostic values of ambulatory blood pressure among the nighttime blood pressure, the 2018 European guidelines in the management of arterial hypertension recommended that the diagnosis of hypertension should not only be dependent on the office blood pressure measurement, but also on out of office measurement, such as our home blood pressure monitoring HBPM 24 hours and night time BP measurement were associated with greater risk of mortality and a composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurement for estimating cardiovascular risk. For every 20 by 10 millimeter of Hg increment of blood pressure measured at night, the risk of mortality increased by 23% and risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guidelines equally recommended five class of hypertensive drugs, considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP target, to start antihypertensive therapy with an initial dual fixed dose combination of AS1 or ARB plus CCB or diuretics. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency of Research on Cancer to be carcinogenic in humans. If 1 lakh patient would have received NDMA contaminated valsartan every day for 6 years in the highest dose, it could result in 22 additional liver cancer over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they have taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits of plus 6%. The HYA study represents the largest study that tested nighttime antihypertensive treatment. In the trial, chronotherapy was associated with significant reduction in endpoints, including death. The HYA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable cardiovascular risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 752 participants experienced a primary cardiovascular outcome. An ambulatory blood pressure was performed for 48 hours to collect data on how BP differed from during sleep. The RR reduction for cardiovascular events was significantly improved for nighttime treatment when compared with awakening treatment. Thank you.